Now we'll talk about the stroke. Usually there are two types of stroke, that is ischemic stroke and hemorrhagic stroke. I want you to understand that ischemic stroke, the most important thing is atrial fibrillation. It is also called as one of the common causes of cardioembolic stroke. What is cardioembolic stroke? It is originating in the cardiac cavity, that is heart, and then it is going to the brain. The embolus is going to the brain, and then there is a large vessel occlusion which is usually presenting as an infarct. I also want you to understand that other causes of infarcts are basically large artery disease such as atherosclerosis. Alright. Whenever there is atherosclerosis, it is usually from the carotids. So that is why we do carotid Doppler in patient who has got an ischemic infarct. Alright. Most of the times whenever there is microvessels that have been occluded, it is usually called as microangiopathy. One of the important microangiopathy is amyloidosis, that is cerebral amyloid. Alright. I want you to understand that atrial fibrillation usually causes multiple infarcts. Large artery stroke or atherosclerosis causes large artery infarcts, and amyloid or cerebral amyloid usually causes lobar hemorrhage. Alright, that is one cause of hemorrhagic stroke. What is the first most important step in the management of the stroke? It is the control of the blood pressure. This is true for hemorrhagic stroke. If the patient has got a hemorrhagic stroke, what do I want you to do? It is the blood pressure monitoring, that is usually 140/90. The patient must be having blood pressure of less than 140/90 is one thing that I want you to understand. Alright. There can be causes of hemorrhagic stroke such as hypertension. There can be carotid artery dissection. There can be vasculitis as well. Alright. What are the risk factors for stroke and how do patient presents in the question or in the examination? The examiner can talk about a 64-year-old woman who is basically hypertensive, diabetes, hyperlipidemia, multiple cigarettes per day. That is a risk factor for stroke. Now presenting with slurring of speech, blurring of vision, unilateral weakness, leg or constant vertigo. That is one form of stroke. Patient can be having weakness of the right hand and also weakness of the dysarthria, or patient is not able to swallow properly. Patient has got dizziness and dysarthria. This can be presentation of the stroke. First most important thing in stroke is you will have to identify when did the symptoms start. If the patient has got a symptom onset of less than 4.5 hours, it is basically treating the patient with thrombolysis. Alright, that's the most important question you will have to understand. If the patient is on apixaban, in which cases most of them will be on apixaban, you must not thrombolyze this patient. If the patient has got a recent surgery, if the patient is diagnosed to have malignancy, please do not thrombolyze this patient. Alright, this is one thing you will have to remember, please. But the most important, most definitive management is thrombolysis. Sometimes you will also have to assess if the patient is able to be suitable for thrombectomy. Alright, I want you to remember this. Alright, now we will talk about some of the signs of the some of the signs of the stroke or infarcts. If the patient has got a cerebral infarcts, it is basically the patient can be presenting with hemiplegia, or patient can be presenting with visual symptoms. Usually if posterior part of the brain is involved or if occipital cortex has been involved, patient usually presents with visual symptoms. Alright. If the patient has got middle cerebral artery infarct, it is usually dysphagia. If the patient has got brainstem infarcts, it is usually vertigo or locked-in syndrome. Yesterday we discussed briefly about locked-in syndrome, where there can be hemiplegia or hemiparesis of both upper limbs and the lower limbs. It is the paralysis of both upper limbs or lower limbs with intact eye movements. That is locked-in syndrome, characteristic of brainstem infarcts. Next we talk about the lacunar infarcts, where there can be infarcts in the basal ganglia or internal capsule or thalamus or pons. Alright. Now, there can be ataxic hemiparesis, there can be pure motor hemiparesis, pure sensory stroke or sensory motor stroke or dysarthria clumsy hand syndrome as well. Remember, all these point out towards thalamic stroke. And what is the rule for thalamic stroke? It is the cognition or the consciousness that are intact in patient who has got thalamic stroke. All right. First most important thing is you will have to image this patient. Whenever you are imaging this patient, please do make sure that a CT scan followed by an MR scan needs to be done. Sometimes CT scan plus CT angio needs to be done. Remember, stroke is a clinical diagnosis. The whole point of making a diagnosis, the whole point of doing an imaging, or the whole point of imaging the patient is to rule out a bleed, because we are giving blood thinning medications for this patient. All right, you'll have to admit this patient, send bloods, full blood count, urea, electrolyte, CRP, lipid profile, HbA1c, and then thyroid. Then you will have to assess the stroke. All right, after doing thrombolysis, you will have to start the patient on aspirin 300 mg or aspirin 75 milligrams once daily and clopidogrel 75 milligrams once daily for 2 weeks, please. All right. And then you can change the medication to aspirin 75 mg for lifetime. If the patient has got a young onset stroke, say for example, if she is a 25-year-old female patient who is presenting with hemiparesis, what is the next best investigation you do? Obviously, we do CT, MR scan and everything. After the patient is stabilized from the stroke point of view, you will have to do an echocardiogram, because we will have to rule out a patent foramen ovale. All right, swallow assessment needs to be done. Until the swallow assessment, you must put the patient on nil by mouth or nil per oral. Next, intracerebral hemorrhage. Some of the pointers that can point out towards intracerebral hemorrhage in the question is, patient can be having sudden headache, patient can be presenting with neurological deficits, and sometimes there can be seizure presentation as well. When you image the patient, you will find a hyperdense bleed. You must not thrombolyze the patient, you must not give aspirin, you must not do anything, but you will have to make sure that blood pressure is managed until less than 140/90. All right. Beta blockers, labetalol infusion can be given in patients with intracerebral hemorrhage. If there is intracerebral hemorrhage, neurosurgical input must be done for the patient. All right. How do you give labetalol is the question in PLAB 1. It is the IV labetalol that needs to be given, please. All right. The target blood pressure is 130 to 140 systolic blood pressure, but I want you to remember it is less than 140/90. All right. If the patient is rapidly deteriorating patient, urgently refer to neurosurgical patients. The examiner is quite interested to test you the complications for intracerebral hemorrhage. Whenever there is intracerebral hemorrhage going on, the patient can be presenting with deteriorating consciousness or deteriorating clinical symptoms, which usually points out that there can be the expansion of the hemorrhage that is happening in the brain. The patient can present with seizures, the patient can present with high hypertension, and the patient can also be presenting with bradycardia, that is Cushing syndrome, that indicates that the patient has got increased intracranial pressure. So this intracranial pressure which is increasing can cause nausea, vomiting. So you will have to make sure an urgent surgical referral needs to be done for these patients. All right. I want you to understand the cardiac causes of stroke, because this is commonly asked. Get an ECG done, you will find atrial fibrillation which causes embolic stroke or multiple infarcts or multiple emboli. All right. Next, we talk about recent MI with LV thrombus. Whenever you diagnose a left ventricular thrombus, I want you to understand that LV aneurysm is usually formed. This is important in cardiology. If the patient has got persistent ST segment elevations even after 6 weeks of treating myocardial infarction, especially in the anterior myocardial infarction, it is the left ventricular aneurysm which can help in the formation of left ventricle thrombus that can cause cardiac stroke. Please understand the question carefully. Patient has got myocardial infarction, patient has got an echocardiogram done, and there is a bag-like or a sac-like structure in the left ventricle. Now the patient presents with the left hemiparesis. You will have to think of left ventricle thrombus, or patient has been having left ventricular aneurysmal formation. If the patient has got cardiac causes of the stroke, say for example, if the patient has got atrial fibrillation, I want you to go with the anticoagulation treatment. What is the treatment of choice? It is the apixaban, please. Alright, apixaban needs to be given in atrial fibrillation, whoever has got stroke. That's it. Next, we talk about the transient ischemic attack. Transient ischemic attack is nothing but a temporary defects lasting for less than 24 hours. Alright, the underlying point of transient ischemic attack is nothing but the patient are prone for high risk of stroke in the next attacks. This is one thing. What do you have to do? You will have to treat it with aspirin immediately. Get a carotid Doppler done for carotid imaging and then take it from there. Alright. So what is the first most important thing? It is aspirin immediately. Sometimes you can give both aspirin and clopidogrel. That is nothing but dual antiplatelet therapy, commonly called as DAPT. If you are interested about the dose, it is aspirin 300 milligrams once daily. The examiner can tell you that the patient is presenting with increasing shortness of breath after starting aspirin, palpitations after starting aspirin. It is the gastritis that you will have to think of. So please start the patient with omeprazole along with aspirin if the patient has got a stroke or TIA, or whenever you are starting a patient with aspirin 300 milligrams. Please do make sure you are giving gastroprotective medications in order to prevent the gastritis, especially called as erosive gastritis, where there can be loss of bleeding that can be happening and patient presents with shortness of breath and palpitations after aspirin use is erosive gastritis until otherwise proved. Remember, for TIA, there is driving instructions you will have to give, and commonly asked, examiners will love to test you. 1 month of driving restriction needs to be done for transient ischemic attack. Alright, next we talk about stroke prevention. If stroke prevention, you are thinking of antiplatelets, aspirin and clopidogrel. If the patient has got atrial fibrillation, it is anticoagulation, that is apixaban. If the patient has got dyslipidemia, it is statins. One most important thing for statins I want you to remember is statins usually has got HMG side effects. Alright, HMG coagulase. The side effects are hepatotoxicity. M is myopathy. These are the two most important side effects for starting statin. Alright. Hepatotoxicity, usually that is a side effect of statin. Myopathy is a side effect of statin. Remember, whenever you are starting statin, you will have to think of or check thyroid levels. Because if the patient develops statin myopathy, and if you have a patient who has hypothyroidism but you did not check the hypothyroid level or thyroid level and started statin, it would be very difficult to differentiate if the myopathy has been started with statin or is it the thyroid induced myopathy. So please do check for thyroid level before starting a statin. Alright, next we'll have to make sure that a strict blood pressure monitoring needs to be done and diabetes mellitus also needs to be controlled, please. Alright. Next we talk about subarachnoid hemorrhage. We already discussed some of the things in subarachnoid hemorrhage. I want you to remember that the subarachnoid hemorrhage is the worst headache of the patient's life. It is usually 10 out of 10 or 9 out of 10. It is sudden onset headache. Sometimes the examiner can tell you that it has been started as 4 out of 10. The severity of the headache started as 4 out of 10. But immediately worsened to 9 out of 10 or 10 out of 10, and this time the immediate worsening must be less than 5 minutes, and the patient classically describes it as thunderclap headache. This is one thing you will have to remember, subarachnoid hemorrhage. Whenever there is subarachnoid hemorrhage, it is usually associated with headache, vomiting, coma and seizures as well. Most commonly, it is basically because of the berry aneurysm rupture, the patient can be having subarachnoid hemorrhage. One most important condition for subarachnoid hemorrhage is adult polycystic kidney disease that is usually associated with berry aneurysms. So, family history is important, and this is important for PLAB 2 as well. What do you have to do? You will have to get an urgent CT scan done, and you will have to do lumbar puncture, please. Lumbar puncture can be done if CT scan is negative. And in the lumbar puncture, you are testing xanthochromia, please. Alright. I want you to understand that you will have to do a CT scan or imaging of the head before performing any lumbar puncture, because whenever you do lumbar puncture and you do imaging, it will cause herniation. There are some signs where you can see it on the CT scan if you do lumbar puncture first and then CT scan next. Alright. So please do make sure that urgent CT scan needs to be done followed by lumbar puncture. Next, we talk about the management. It is the neurosurgery referral if the patient has got subarachnoid hemorrhage. There is this famous medication called nimodipine, which is usually given to reduce the vasospasm of the arteries that are affecting subarachnoid hemorrhage, and this is subarachnoid hemorrhage. Alright, you can clearly see the blood in the basal cisterns and in the cistern as well. Alright, next we talk about the subdural hematoma. Subdural hematoma is slowly expanding bleed because this is a venous bleed. This is present in between the dura and arachnoid matter. I will tell you a famous question where the patient has been presenting with the recurrent falls, patient has been alcoholic, patient is on anticoagulation, presenting with multiple falls. Now patient is confused with the gradual deterioration in the confusion or fluctuating GCS and personality change. Please do think of subdural hematoma. Whenever you think of subdural hematoma on the CT scan, there is a crescent shaped bleed. You will have to treat the cause for subdural hematoma. Sometimes you will have to stop the anticoagulation, and you can also do craniotomy or burr hole surgery. Alright. This is subdural hematoma. Next, we talk about extradural hematoma. This is an arterial bleed. Whenever there is an arterial bleed, it is rapidly expanding hematoma. It is because of the middle meningeal artery that has been ruptured. So, patient usually presents with the rapid deterioration with the raised ICP, for which the examiner can tell you that the patient has got headache, nausea and vomiting. That is the feature of raised intracranial pressure. What is the CT scan show? It shows biconvex or lens-shaped hematoma that is characteristic of extradural hematoma. How do you manage this? It is an urgent neurosurgical evaluation that needs to be done. Alright. Next, we talk about cerebral venous sinus thrombosis. Remember, whenever you are thinking of cerebral sinus venous thrombosis, it is young female around 30 with OCP use or pregnancy or obesity presenting with a headache. That is one most important thing for cerebral sinus venous thrombosis. Patient usually presents with headache, seizures and focal neurological deficits. I want you to understand that the diagnosis of cerebral venous sinus thrombosis is MRI or the CT venogram that is usually done. Alright, how do you manage it? Immediately treat it with anticoagulation such as low molecular weight heparin, but the best management is warfarin. If you do not have low molecular weight heparin, please go for warfarin. The most important differentiation you will have to remember is anticoagulations are useless in cerebral venous sinus thrombosis. It is the low molecular weight heparin or warfarin that is usually treated. Alright, next we talk about idiopathic intracranial hypertension. Whenever you find a question on a young woman presenting with eye pain, back of the eye, blurring of the vision, patient has got fundoscopy, patient has got headache, papilledema, then you will have to think of idiopathic intracranial hypertension. One most important thing I would like to tell you is patient presenting with headache, with deterioration in the vision and is obese or is pregnant or has got use of tetracyclines or vitamin A or sulfasalazine or doxycycline. These are all pointers towards idiopathic intracranial hypertension. Obese young woman, raised intracranial pressure with normal imaging points out towards idiopathic intracranial hypertension. The symptoms are again headache, visual loss, and papilledema, which is best seen on fundoscopy or optical coherence test done by the ophthalmologist, please. When you do a lumbar puncture, it is usually more than 25 centimeters of water that the pressure has been raised. And how do you manage this? It is the weight loss, it is the acetazolamide, and it is the surgical shunt that is needed for idiopathic intracranial hypertension. Alright, next we talk about delirium. Remember, for delirium, if the patient has been admitted to the hospital or in the ITU or has got a recent surgery, and now the patient has got an infection and is not able to appropriately oriented to time, place, and person, that is delirium. I want you to understand that the patient will be having visual hallucinations or patient will be having acute fluctuations in the cognition. You will have to think of delirium. Remember, the patient is perfectly alright before admitting to the hospital or before undergoing any surgical procedure or any stressful reaction to the body. Now the patient presents immediately with the confusion and everything, then you will have to think of delirium, which is an acute confusional state within the hospital setting, that is delirium. First most important thing is you will have to rule out infection. There are other risk factors for delirium as well, because the patients can be elderly patient who has got underlying dementia or previous cognitive impairment or previously undiagnosed memory problem. There can be psychological agitation. Sometimes patients can be in pain. For delirium, you will have to think these risk factors. Alright. Please do screen for infections. Please do screen for chest infection, urinary tract infection, pain, any head injury, any bleeding in the brain, any infarcts. Think of alcohol withdrawal. Think of cardiac failure. Think of thiamine deficiency as well if you are thinking of delirium for this patient. Alright. What is the management? It is, you'll have to treat the cause, first most important thing. Next thing is reorient the patient. Sometimes you can use haloperidol as well. But please do avoid haloperidol if the patient has got Parkinson. Alright. Next we talk about dementia. One most important thing I want you to understand for dementia is the identification of dementia or diagnosis of dementia. Lost in neighborhood is Alzheimer's disease. Stepwise cognitive decline with vascular risk factors such as smoking, hypertension, diabetes mellitus or hyperlipidemia, it is vascular dementia. Patient has got visual hallucinations, patient has got night terrors, sleep problems. Think of Lewy body dementia. Patient has got vigorous visual hallucinations, you will have to think of Lewy body dementia. If the patient has got personality change, think of frontotemporal dementia. And before diagnosing a dementia, the examiner will tell you what is the first most important step. First most important step is to rule out the reversible causes. So please do rule out the reversible causes by performing full set of bloods, thyroid levels as well. And then go for investigations that can be CT scan or MR scan. Alright. You can also do MOCA as well. Alright. These are the most important differential diagnosis for dementia. Again, remember, not remembering names, forgetting the neighborhood. Lost in neighborhood is Alzheimer's dementia. Stepwise decline with vascular risk factors, history of multiple strokes, it is vascular dementia. Lewy body dementia is basically because of the Lewy body dementia usually is characteristic of visual hallucinations. Frontotemporal dementia is usually associated with personality changes. Alright. Next we talk about CJD. CJD is basically a prion disease. I want you to understand that rapidly deteriorating dementia followed by death is characteristic of CJD. Patient can be having myoclonus, but the most important thing I want you to remember is patient who has got rapidly progressive dementia, within less than 6 months the patient will be dying. So please do remember that. Alright, then this can be investigated, the MRI can be done, but remember the definitive investigation for CJD is RT quick. This is a new investigation we are doing. Usually it was CSF 14-33 prion protein that is usually seen. All right. What is the prognosis? The patient will be gone in few months. All right. Again, Alzheimer's dementia, we discussed this is most common cause of dementia. I also want you to understand that Alzheimer's dementia is associated with ApoE4. Alzheimer's dementia is also associated with the Down syndrome, which is trisomy 21, and this trisomy 21 is the one which is involved in Alzheimer's disease. Whenever you do the pathology or biopsy, you will find amyloid plaques and neurofibrillary tangles. How do you manage patients with Alzheimer's disease? It is the medications such as acetylcholinesterase inhibitors and memantine that can be used for Alzheimer's disease. Talking in depth for the pharmacological treatment of Alzheimer's disease, I want you to understand that it is the donepezil, rivastigmine and galantamine that is effective for Alzheimer's dementia. Sometimes the examiner can also ask you about memantine, which is an anti-glutamatergic treatment. All right. There is this new treatment called as amyloid beta monoclonal antibodies. What is it? Amyloid beta monoclonal antibodies, which is usually called as aducanumab, which is a monthly infusion. All right. These are the things you will have to think of. All right. Next, we talk about this completes our Alzheimer's dementia. I will see you soon in the next session. Thank you very much for attending and all the best.